Hi, everybody. Thanks for joining me today. My name is Dr. Melissa Rayhill. I'm an assistant professor of neurology at the University of Buffalo School of Medicine, SUNY Buffalo. I was also the associate clerkship director a couple of years ago, and now have transitioned into the associate neurology residency program director position this past year. And I'm the incoming residency program director starting this July. I don't yet have a fellowship, but I have been in touch with a lot of my friends who are fellows and friends who are fellowship directors, so I can speak a little bit about that as well today. I would like to spend this time with you today talking about the options for virtual education, given what we are all up against with coronavirus, COVID-19. It's been pretty remarkable, the transformation that has occurred in such a short amount of time. I would like to dedicate my talk today to an amazing educator. I just found out passed recently, so this goes out to her. So for those of you just joining us again, my name is Dr. Melissa Rayhill from the University at Buffalo School of Medicine. So let's see here. So I would like to first talk about how we not only have the responsibility of keeping our trainees safe, but we also have a duty to continue to educate them, not only for our trainees, but also for our patients, so that they can better serve our patients with headache. We all know we need it. When this all started to happen, we pretty quickly tried to make swift changes, not only in our clerkship, but also in our residency program here in Buffalo. So I'll speak a little bit about the changes that have occurred for our medical schools, medical students, as well as our residents. And I will also touch upon, fellowship considerations as well. So with regard to medical students, I was on the phone last night with our head of medical education at the University of Buffalo. She's awesome. We're very lucky to have her as a resource. And she said that everybody basically sat down for all of our clerkships and talked about reviewing the clerkship objectives for every course, and really thought about what was absolutely necessary for people to do in person and what could be done virtually, so that our students are still achieving all of the educational objectives for the course. So I would encourage you to do the same in your institutions as well. We are right now at Buffalo postponing our in-person requirements for our clerkships to a later date, and really focusing 100% on virtual education for our students. So one of the first things I did, I think it was like the first or second day I started to work from home, I recorded my lecture on headache medicine that I usually give to our fourth year medical students for their clerkship. I recorded it on a program called Panopto. It was a little challenging to get used to at first, but it's actually pretty easy. And so they can, see my PowerPoint, they can hear my voice, I can do a little editorializing when I'd like to, and it's there for them so that every single module, they can reference it. One of the other things we're doing in the clerkship, we're having virtual table rounds. So not only for our neurology clerkship, but for medicine clerkships and other clerkships at our institution, for the hospitalized patients, they're actually having students virtually tune in and talk about the patients that are on the service, so they still get that education, but they're also being protected so they can do so at home. For small group activities for our students, Dr. Mecca, who's our medical education director, has devised these ways to do small group breakout sessions within Zoom, which is really cool. So it's not that they're having to just listen to somebody talk forever. They have a case presented to them, and then they're given a series of questions, and then they can break out in small groups, just like we would do in person at our medical school. So that's another option if you're not aware of that feature. They're also asked to write notes, progress notes, and there's a grading rubric for progress notes and a grading rubric for discussions. Interestingly, our clerkships have gone to pass fail because unfortunately you can't really compare its apples to oranges with the other clerkship grades, and I'm curious to see how other institutions will follow as well. Specifically in our neurology clerkship, um, for the fourth year medical students, it's largely an inpatient rotation for them. We do have an advanced neurology rotation, which is mainly outpatient, but that's more popular during the fall, given the interview season, et cetera. So, if we do have students in the outpatient realm, we can certainly incorporate them into telehealth, which I'll talk about. But for our inpatient experiences, we have the opportunities I just spoke about, but in neurology, we've started to do sort of group presentations on different key topics in neurology. I have to say, it was actually kind of fun. So we had about, I think it was between 8 and 10 students in the session. And I think we had probably 4 faculty members on the call. And I have to say, I really, truly enjoyed hearing my other fellow faculty members teach the students about, bread and butter neurology, talking about brainstem pathways and all sorts of fun stuff. And it was great. I learned new tricks. I'm sure they did too. And I think that our students really enjoyed it. So we had the students come up with, 4-minute PowerPoint presentations, a couple of which were in headache topics, which I loved, of course. And basically, after the student was done, we just asked them a couple of questions, gave them a couple of clinical pearls, and had some good discussion usually. So not only was it sort of fun for the students and faculty, I actually think that I learned ways to become a better educator myself. So I think that that's going along pretty nicely so far. Okay, so I'm going to move on to talk about our residents and how to support our residents. Not only for headache medicine, but also for neurology. And I'm sure it can be applied to multiple specialties as well. So I've been worried sick about our residents, and I think initially when this all happened, I'm sure it was the same in other institutions. It was sort of a piecemeal response, and I felt personally strongly that I wanted to convert to telemedicine as soon as possible to protect myself and my patients and my staff. So, I think when everybody did that sort of piecemeal, the resident continuity clinic made changes sort of a little bit later. But I really pushed to try to get them out of in-person visits as soon as possible. So I experimented with a few different platforms for telemedicine. I've experimented with DoxyMe, Zoom, Skype. There's all sorts of different options. What I ended up doing for our residents for telemedicine for their continuity clinics is I chose DoxyMe because you can open different tabs for each resident's clinic. So we have 3 residents at a time on Mondays and on Tuesdays, and they're also at other sites like the VA and a county hospital. So at our site, it's 3 residents at a time. So you can really easily toggle back and forth between the tabs, and they can invite you into the waiting room when they're ready to staff the patient over video. And then they can initiate a 3-way call with the patient. So you can directly observe the patient, the resident, do an exam. And it actually works very similar to in-person continuity clinic. I think that it's been well received by patients and residents. I think everyone is thankful to be getting care in a safe environment. I'm happy to discuss the logistics of how I set up the resident accounts on DoxyMe a little bit more if people have questions. So it's also important when residents are on outpatient clinics and elective rotations. So I have a lot of residents who do headache medicine elective with me. So in those circumstances, we can either use DoxyMe, but to do three-way calling on DoxyMe, you have to have an upgraded form of it. So sometimes I'll just use Skype. During the national emergency, as I'm sure many of you already know, the government has allowed us to use non-HIPAA compliant platforms like Skype and FaceTime. Obviously, you have to do so with patient consent and appropriate documentation. But for my elective and outpatient encounters with residents in my headache clinic, I'm mostly using Skype, and it's worked out pretty well. Um, if before all this happened, if a resident had to come in late to my clinic and catch up, I always had the practice of sitting down with the resident when I had an extra few minutes and telling them about the morning thus far, the patients that they missed. And I'll do a quick case presentation and I'll just ask them, so what would you have done? What medicine would you have started, et cetera? And then I review what I actually did. And even those case presentations can be very helpful. I'll also ask them about, patients that they saw in their continuity clinics with headache, and we have great discussions. So it's an important reminder that you can still be having these discussions remotely with your residents. In terms of resident didactics, so we've moved resident didactics completely to Zoom. And because the lecture series are not as frequently repeated as for our medical students, we're doing the lectures live, which I think has been well received, and faculty have been great at stepping up to meet that challenge. We also have moved our journal club for residents virtually, and there's definitely a lot of trials in headache medicine that need to be reviewed for our residents. So we have a standard question list on how to approach important journal articles, and that can all be done virtually as well. It's a great educational opportunity. We have an annual resident research day that is we're planning on moving to be completely virtual as well. And the AAN content from the annual meeting from 2019 has also been made available, thankfully. So our residents are supplementing their educational exposure with that content as well. So another point about supporting our trainees, our residents in particular, it has just been such a hard time for everybody. And I know I personally have derived so much support and guidance, and just have felt so validated by talking to my colleagues. And I want to give a shout out to our Migraine Mavens group. They have been so wonderful, and I would have felt lost without you all. So doing those sorts of sort of social professional support meetings on platforms like Zoom is so important right now. And so I propose to have a resident town hall because particularly for our residents who are in the hospital, there's a lot of understandable anxiety and fear. And I want to make sure that we're supporting them and giving them a platform to express those concerns. I also encourage our chief residents to kind of host one even without faculty, so that residents could feel free to, sort of express themselves without faculty around. Earlier on in the year, we started these once quarterly social gatherings for our entire department, including faculty. They're unofficially called cerebellar rounds, but a lot of the faculty have reached out recently too, just requesting that we start that up again on Zoom. So I can't emphasize that point enough. We need to support our trainees socially as well, because if you're anxious, if you're scared, I know I've been having trouble concentrating lately, and you can't learn in that setting. So we have to support each other so that we can really get down to the business of learning and educating. So in the last few minutes, I just want to touch on some issues with fellows and also with inpatient headache medicine and inpatient neurology. So I think The fellowship programs differ slightly in that some have fellows who sort of are more independent and can bill independently, and then some programs, their fellows cannot bill independently. So that's going to affect the required direct supervision for each individual program. But as I've laid out with the residents, I think it's very doable to directly supervise your fellows with telemedicine. Thankfully, we have the technology to be able to do that. And then there are inpatient challenges too. I know there are a lot of wonderful headache programs in our country that have very robust inpatient components to them. And obviously, we want to be keeping our patients out of the hospital as much as possible. But as many of you know, headache is one of the symptoms of COVID-19. And so, when we are asked to be involved in the care of patients with headache in the hospital, we have to be taking extra precautions. I know at our institution, I've been very vocal about the need for adequate personal protective equipment. But because that is a hot commodity these days, I'm really pushing our residents to obtain everything that they can remotely, and just be a little bit more purposeful about how we approach inpatients in terms of what is actually required to meet their needs, what is required in person versus virtually to meet the patient's needs and to provide adequate care. So, for example, a lot of our history in neurology, well, I should say, my former residency program director always used to tell me that you can arrive at the diagnosis 90% of the time by history. So we should be taking advantage of the power of our history taking. And there are phones to use in the patient rooms in the hospital. There are iPads at my institution to facilitate telehealth and video options for patient evaluation. But obviously, there are instances in neurology where you just really need to do a good exam to answer a clinical question well. So in that case, we should really stop and think about what exactly in the examination would change our strategy. So, for example, I wouldn't recommend that our residents do a complete full neurologic examination with fundoscopic exam and all in the age of COVID-19. So it really requires close communication with the attending and the resident together, or in this case, the fellow and the attending together. And you really have to come up with a good game plan to keep everybody safe.